Right. We move on to our next session on the topic remote health discovery. Our speaker this afternoon is Avinash Babu M, founder and CEO of Svasthya Health. Avinash brings 17 years of experience in building product development teams to cater to multiple geographies and verticals, namely CE, medical, assistive, IoT, industrial, and defense electronics. One of the early members of the Mistral Solutions and Embedded Product Design House, he has been instrumental in building the product engineering services vertical. Ladies and gentlemen, please welcome Avinash Babu.
We just need 30 seconds to set this up. Yeah, good afternoon, everyone. So we were between you and your lunch, I guess, so we'll try to make it quick. First of all, thanks, NASSCOM, for providing this opportunity. We like this idea of tech in action. I think it separates the doers from everyone else. And we are here to provide you an overview of how future of health tech is seen through the lens of technology itself. So we at Svasthya provide remote clinical intelligence to doctors for triaging, assessment, and remote dissemination. Hospitals are sanitized environments while the need is outside. That's where we play the part in connecting the hospitals to the doctors. While we analyzed the situation, we saw that the main reason for this health deficit is cognitive, financial, and structural barriers. We are here to resolve this through early presentation, increased prevention, and increased care. The problem that we are trying to solve is unoptimized health outcomes, lack of trust in some ways, physician burnout. And there is a $13 billion market in primary healthcare which nobody is taking up for reasons that there is no platform to build a profitable mechanism and dissemination at scale. We are solving this problem uniquely by providing ambulatory medical clinical grade solution that can work in multiple low resource care settings, that is easy to adopt, and works in alerting and providing the care coordination. So what we ensure centrally is trust, safety at convenience. That's what I think we need for adoption. We provide clinical actionable data along with patient context assessment and a way to disseminate care. This will lead to a complete workflow of treatment, which finally will lead to referral pathways and care coordination as required. Along the path, we build the system in an interoperable manner. We know we cannot solve this problem by ourselves. And at the center of it, we are here to connect the clinical intelligence to clinical data. And I think that's the gap that's missing today. So Svasthya is a unified digital infrastructure for healthcare. It has three parts, which is biosensor, cloud infrastructure, and downstream applications, which, like I mentioned, provides physiological data, patient context, so that we can triage, we can give risk assessments, and use it in step-down, ambulatory, home care, and incident care. We look at it for acute, chronic, palliative, and geriatric conditions. So this is a small video of what we are doing. Sorry, the audio is missing. So this is where we play the part to the complete journey, where we are screening for Government of Karnataka. We also work with Shankara Cancer Care Hospital, vitals plus symptoms, and providing early morning score. This is step-down care for a CKD patient in a hospital. You can see the alerting, you can see the EWS score over there. This is for a dengue patient. The doctor is remotely getting alerts based on health derangement. This is a home care setting. We work closely with the Umeå and Rice University in Sweden. So the doctor is looking at a geriatric patient because she has informed that she is feeling unwell, and then this will be left with her. This is a incident care. This is a mocked up scenario. This is happening, in fact, between Sweden and India, if you really observe it. So the doctor is looking at the vitals and providing support to the paramedic at the site of incident so that the response within the golden hour is high quality. So this is the teleconsultation that we are doing along. You can see the ASHA worker in between. That is the patient who is diabetic. Unfortunately, the audio is not playing. So this is the doctor who is consulting with the patient and then providing care. So this is another scenario where this lady is explaining that she has had allergy all over her face. Unfortunately, the audio is not playing. And then the doctor is recommending certain medications. I mean, we cannot show the whole thing. We have shown snippets. The doctor captures the vitals and then takes this decision. So as we do this, we are moving forward. We have taken the opportunity to show it working. So we have two very experienced doctors sitting with us today. One is Dr. Sanchita, who is the COO of the National Cancer Care Program at Shankara Cancer Care Hospital. Next is Dr. Halima, who is a senior diabetologist. She is the Vice President of HIMSS. She was a global icon during the G20. So we will take you through two sessions. One is screening, outreach, and clinical research. Dr. Sanchita, it's yours.
Thank you, Avinash. So we'll just walk you through what we do on the field. We have adopted Chikbalapur district and specifically Chintamani Taluk. So our team is there right now and they're doing door-to-door systematic screening for oral, breast, and cervical cancers, the three most common cancers in India. So the field worker there has entered the details of a person with tobacco history. I'm going to assess it remotely. The data has been captured. So there is a screening camp happening right now. So this was taken about less than an hour ago. So his vitals seem okay to me. I'm not concerned about any of this. So the field worker has done preliminary screening as is required as per the National Cancer Control Program guidelines that we have. So he thinks that there is a red patch. They've taken comprehensive photographs of the oral cavity. And he thinks that where is the red patch? It's in the right buccal mucosa, he says. So these are the photographs that I have. And I will glance through it. This is the right buccal mucosa. I'm going to open it. So this patch here that they are noticing, the field workers noticing, could be just the stains or could be pre-cancer. Now, why are we doing this? I will just give you a brief. But now that I have seen all the lesions, I am not too concerned. Probably here he has bad oral hygiene. He has a risk of developing any lesion here. So I will continue. The first thing that they need to know, a lot of us do not know, is not just tobacco, but betel and areca quid chewing also causes cancer. This, to a large extent, is not known to many in the rural population. So I will give him an intervention. What I need him to undergo is cessation counseling. So I've finished that. We have the team there, so I will also talk to him in person and give him the counseling. And we'll just try to connect to him. ನಮಸ್ಕಾರ ನಾರಾಯಣ ಸ್ವಾಮಿ ಅವರೇ, ಹೇಗಿದ್ದೀರಾ? ಓಕೆ.
ಒಂಥರ ಜುಲ್ ಜುಲ್ ಅನ್ನೋದು, ನರಗಳು ಎಳೆಯೋದು.
ಹಾಂ.
ಈ ಎಡಗಡೆ ಸ್ವಲ್ಪ ಸೋತಿನ ಕಮ್ಮಿನಮ್ಮ.
ಸರಿ, ಇವಾಗ ನೀವಲ್ಲಿ ಕ್ಯಾಂಪ್ ಹಾಕಿದೀವಲ್ಲ, ಸ್ಕೂಲ್ ಹತ್ರ ಕ್ಯಾಂಪ್ ಹಾಕಿದೀವಲ್ವ, ಅಲ್ಲಿಗೆ ಹೋಗಿ ಅಲ್ಲಿ ಡಾಕ್ಟ್ರ್ ಇದ್ದಾರೆ, ಡಾಕ್ಟ್ರ್ ನೋಡ್ತಾರೆ. ಮತ್ತು ನಿಮ್ಮ ಬಾಯಲ್ಲೆಲ್ಲ ನೀವು ಎಲೆಡ್ಕೆ ತಿಂದು ಕೆಂಪಗೆ ಮಚ್ಚೆಗಳಾಗಿದೆ, ಆ ಮಚ್ಚೆನ ಅಲ್ಲಿ ತೋರಿಸಿ ಅಭ್ಯಾಸ ಬಿಡೋದು ಹೇಗೆ ಅಂತ ಹೇಳ್ಕೊಡ್ತಾರೆ. ಅಲ್ಲಿ ನೀವು ಕ್ಲಿನಿಕ್ಗೆ ಹೋಗಿ ಅಲ್ಲಿ ಇವಾಗ ಔಷಧಿ ಎಲ್ಲ ಕೊಡ್ತಾರೆ, ನೋಡ್ತಾರಪ್ಪ.
ಅಭ್ಯಾಸ ಏನೂ ಇಲ್ಲ ಮೇಡಮ್.
ಹಾಂ,
ಅಭ್ಯಾಸ ಏನಿಲ್ಲ ಮೇಡಮ್ ನಮ್ಗೆ.
ಎಲೆಡ್ಕೆ ಹಾಕೊಡೋದು
ಮುಂಚೆ ಇತ್ತು.
ಹಾಂ, ಮುಂಚೆ ಇದ್ರೇನು ಬರುತ್ತೆ. ನೀವು ಅಲ್ಲಿ ಡಾಕ್ಟರ್ ಹತ್ರ ಹೋಗಿ ನೋಡ್ತೀರಾ. ಇವಾಗ ನೀವು ಹೇಳಿದ್ರಲ್ಲ ನೋವೆಲ್ಲ ಇದೆ ಅಂತ, ಬಾಯಲ್ಲೇ ಫೋಟೋ ತೆಗ್ದಿದಾರಲ್ಲ, ಅವ್ರು ತೋರಿಸ್ತಾರೆ ನಿಮಗೆ ಬಾಯಲ್ಲೇ ಕೆಂಪಿಗೆ ಹೆಂಗಾಗಿದೆ ಅಂತ, ಅದನ್ನ ನೋಡಿ ನೀವು. ಹಾಂ, ಸರಿಪ್ಪ, ನಾವು ಅಲ್ಲಿಗೆ ಹೋಗಿ ನಾವು ನೋಡ್ತೀವಿ. For want of time, I had to cut short the conversation, but there are other doctors on the field who will attend to him. Now, why is this important? India contributes to 1/3 of all cases of oral cancer in the world. And a lot of these oral cancers are preceded by oral potentially malignant disorders that can take anywhere between a year to 5 years to 10 years to transform into cancer. Now, we are looking at 2 lakh new cancer cases every year, and by having these active screening programs, we'll be able to treat them at their precancerous stages so that they don't develop into full-blown cancers like that. At our camp setting, we're using Svasthya in the last few months. We have seen a 35% increase in the reach of these screening services to population like this. Not only will be able to step down, we'll also be giving them cessation counseling through the video consultation, which is essential. So with this, I'll leave you here. Thank you.
Okay, so just to continue this, we'll set up another thing for step-down care and ambulatory care. So Dr. Halima, if you could come in. So we said there's a home care patient with whom Halima is going to interact.
Okay, thank you, Avinash, and very good noon to all the audience over here. Okay, I mean, the lesions you saw here were much, easily, I would say, accessible to the doctors, and the diagnosis is just made in a jiffy. So what is the next best thing after the images like this? Having live vitals on screen. How many of us, when we connect to doctors who are on telemedicine practice, record vitals prior connecting? In the audience, tell me how many of you, when you call your doctors, check your temperature in a thermometer and then call the doctors? How many people? Hardly one in the whole audience. When we received the call on the other end, we received the call stating that, Doc, I have fever. How much is it? I use the dorsum of my palm. Looks like it is there. So this we cannot decide. We have to have quantification in terms of number. How is that possible? So what I do generally for my patients, I stay on the call, I stay all hold, ask them to record the temperature and let me know at the same moment. The decision making at this moment, especially for pneumonia and to rule things out, is very important in terms of number. When Svasthya is providing us a live platform wherein the vitals can be recorded as I talk to the patient, I guess nothing like it. So here we have a live patient whom I'm going to consult and see the vitals at the same time. So, Namaskarama. ನಾನು ಡಾಕ್ಟರ್ ಹಲೀಮಾ ಅಂತ. ತಮ್ಮ ಹೆಸರೇನು? ಲಕ್ಷ್ಮಿ ಅವರಾ? ಆಯಿತು. ತಮ್ಮ ವಯಸ್ಸು ಎಷ್ಟಮ್ಮ?
ವಯಸ್ಸು 77.
ಓಕೆ. ಏನು ತೊಂದರೆ ಆಗ್ತಿದೆ ಈಗ ನಿಮಗೆ? ಏನು ತೊಂದರೆ ಏನಿದೆ?
ಏನು ಅದರಿಂದ ತಲೆನೋವು ಇತ್ತು.
ಎಷ್ಟು ದಿನದಿಂದ ತಲೆನೋವು? ಯಾವಾಗಿಂದಮ್ಮ?
ಅಷ್ಟು ಬಿಟ್ಟರೆ ಮತ್ತೆ
ಓಕೆ. ತಲೆನೋವು ಯಾವಾಗಿಂದ ಇರೋದು?
ಒಂದು 2-3 ದಿವಸದಿಂದ ಇದೆ. ಇವತ್ತು ಸ್ವಲ್ಪ
ಕಮ್ಮಿ ಇದೆ. ಜ್ವರ ಇದೆಯಾ?
ಇಲ್ಲ.
Okay. Can I see the vitals? Okay, the patient just told me she has headache for the last 3 days. Being a doctor, headache can have multiple reasons. One, there could be an infection. Two, looking at her age, we could be having a complication of hypertension. Three, we could even have an impending bleed. There are multiple reasons for a headache. How do I decipher it? How do I know? One, history. Two, the vitals. So I have the vitals which are live over here. The saturation, that is oxygen level, is 97%. Heart rate is very high, which I attribute this to the pain. Temperature is not much, so infection is more or less ruled out. The BP, the systolic, the upper part is slightly on the higher side. Possibly she is anxious because of the pain as well. So at this juncture, I would, after this call, I will consult her much in detail. I'll provide her a prescription for the particular pain management, because I know at this point that the pain she's having could just be a tension vascular headache, or it could just be a cluster headache, which doesn't warrant attention at the earliest. As in the contrary, if the BP here would have read 150/100 or 150/110, and she complains of headache like this, the next thing I would have asked her is, rush to the emergency. I would want a scan on you. How easy is it for me to convince the patient? If I have the blood pressure and the vital readings in front of me, it makes everything very, very easy. How many of us suffered during COVID, not knowing whether to get to the hospital or not? And what was the decisive factor? The 94% saturation. I'm sure everyone agrees with me. Everyone at home has a pulse oximeter now, isn't it? During COVID days, the way to triage was the pulse oximeter. So remote monitoring with the vitals like this would go a long way in helping the patient care. So having said this, I think Svasthya is doing a great job getting us the live vitals from the time of consultation. During the consultation is a big, I would say a step forward in patient care. So step down ICUs and home health cares, I would say this would basically go a long way. There are hospices wherein there are cancer patients who basically don't require hospitalization but require constant care. So these can use devices like this to get in touch with doctors with vital signs being recorded live. Having said this, thank you so much. Thank you, Svasthya, and thank you, NASCOM. Thank you.
Yeah, while this is going on, I think we have one more case, which is ambulatory care. Time's up, but just give us another 3-4 minutes. I think we should be done with it. So, yeah, Dr. She was. So the whole idea is whatever accuracy that we're demonstrating, you might be wondering if it's stationary, but we are doing it in ambulatory setting. So we have kind of, this is our colleague. I mean, I'll get Halima to talk to you.
Hello. Yeah, so do you have any complaints?
I had pain in my
Okay, pain in your left arm. Where exactly does it pain?
It was paining at this portion.
Okay, any chest pain or left upper back pain?
No, doctor, I didn't notice.
Okay, great. Okay, do you smoke? No. Okay, so can I see the vital signs? Okay, the saturation is good, the heart rate is good, there's no temperature, there's no fever, BP is stable. So looking at this, and there is a ECG running, which is good. So a young male with left arm pain, it's the most problematic, decision on telemedicine. It's a cardiac origin or muscular origin. If I have a ECG running there, which can give me insight about the cardiac condition, it makes things very easy. So now I can definitely, looking at the ECG and the vital parameters, I can conclude it could just be a muscular pain. Whereas we have youngsters who have cardiac issues, have similar pain just in the left upper arm, and some people just have a tooth pain, jaw pain, and there could be an ongoing MI. How do I know that on a telemedicine consultation? If I have something like this, if I have someone to back me up with the vitals, it can do wonders. So at the moment, I can conclude easily that this person just having muscular pain and provide him with analgesia. Recently, I think we had a young girl who was gymming and suddenly had a cardiac arrest. We are seeing many patients like this. I always tell that we have to go in for preventive healthcare checkups as frequently as possible. And any kind of pain, any kind of chest pain, even if you think it's a mild pain, get the doctor involved and don't neglect this. So if I have a 12-lead ECG running on the patient, as I talk to them for the chest pain, it just does wonders in preventing sudden deaths and cardiac arrest. So again, thank you for giving the opportunity. And I guess even the patient is moving and the vitals are recording pretty well, which is definitely what we would want to take the healthcare forward and prevent sudden cardiac deaths, which is happening of late. Having live vitals running definitely does the job. Thank you, everyone. Again, thank you, NASCOM. Thank you, Avinash, and thank you, Svasthya.
So we'll quickly conclude this. If you go to the concluding slide. So we've also been awarded the Swedish Innovation Award for Life Saving from Distance, some of the coverage, some of our launches. What we want to do, our goal is clinical health at every doorstep. That's our mission. And we want to make the doctor's job a 9 to 6 job. I think if there are any doctors, they can relate it to this. So I think that's where that will ensure the quality of care goes tremendously high. And our ask is collaborations and connects with enterprises, with hospitals, Ministry of Health, PHFI, AHPI, and last but not the least, patient capital. Deep tech requires capital. We have a few people on board. Taking this to scale needs patient capital. I can show unit economics, right? But when you ask for paying customers with millions of dollars of revenue, it needs patience, because data, the area is sanctified, the technology is not very, very well proven. So NASCOM is helping us in a big way in that. And I have the same request to the audience. We are open to collaborate. Thank you, NASCOM. Thank you, everybody. It was great speaking here. This is the start of the journey. There are a lot of things left undone. Thank you.
On that note, we'd like to thank Avinash Babu and his team for that very interactive and informative session. I'd like to request Tilak from NASCOM to present Avinash Babu and the team with a small token of our appreciation. As we thank them, we'd like to request you to please give them a big round of applause once again. Thank you.
We also have a stall here. I mean, anybody interested, please come. And if you were wondering how the vitals were coming, this is the one. This is completely made in India. It is as good as a multi-parameter monitor that you see in an ICU. We use only electrical activity and PPG.